Fantastic. Good morning.
Good morning.
Good morning.
Thank you for coming out this morning. It's actually sunny and not freezing morning. I appreciate you choosing to spend your time with us today. So my name is Dr. Underwood. I'm a neuropsychologist at U of L Fraser Rehab Brain and Spine Institute. I've had the privilege of speaking to this group now for 4 years, I think.
I think it's 4 years.
So I see a couple familiar faces. You guys have probably heard this already, but hopefully it's a little different than last time if you've already heard the presentation. But I like to keep it informal to some degree. I have a slide deck. I usually have an ambitious slide deck. I like to get through a lot in a short period of time. So I might rush, but if you have any questions, comments, anything like that, please feel free to jump in, raise your hand, okay? So I don't know if anybody really knows what a neuropsychologist is. Not many people do. A neuropsychologist is kind of like a neurologist and kind of like a psychologist. We're kind of in between. So I'm a PhD licensed psychologist with extra training in neurology and brain neuroanatomy and brain diseases and injuries and illnesses, things like Parkinson's disease and traumatic brain injury and seizures, tumors, strokes, things like that. So we kind of see patients for evaluation of thinking and mood, dementia, changes related to any disease that might affect the brain and mood and behavior. So that's kind of our area of specialty. So what we're going to do is today talk about depression, anxiety, and apathy, and the mood changes that can occur in the setting of Parkinson's disease. Okay? So we typically think of Parkinson's disease as a motor or movement disorder, right? That's what everybody kind of thinks about classically. And we use the acronym TRAP. T for tremor, R for rigidity, A for akinesia, and P for postural instability. That's kind of the classic TRAP acronym for the cardinal features of movement problems, whether we're shaking, whether we're stiff, whether we are slow in our movement, or whether we don't have very good posture. But wait, right? Well, I know I like this slide, right? It's more than that. It's more than just movement. And this is where I start to get real passionate about this disease, because my dad had Parkinson's disease, and he had kind of the entire constellation of movement and non-motor symptoms, okay? So there was a real important article that came out in 2011-ish or so by a guy named Weintraub, who kind of reconceptualized Parkinson's disease as more of a neuropsychiatric disorder, okay? And so why? Well, because dopamine affects and controls and regulates not just movement, but emotions, motivation, impulse regulation, and thinking, okay? So when we think about Parkinson's disease, we know it kind of starts in the gut and works its way up to the brain, right? And so it starts kind of in these lower parts of the brain here, right? All the substantia nigra compacta and the ventral tegmental area, and this is where the dopamine is produced. And then it kind of sends dopamine along 3 different pathways. It sends it along a pathway called the mesolimbic pathway, the mesocortical pathway, and the nigrostriatal pathway. Okay, and all those pathways kind of lead to different parts of the brain and do different things. So the nigrostriatal pathway goes to these more subcortical, lower parts of the brain, and it's involved largely in movement and control of our body coordination. And then we have another pathway called the mesolimbic pathway that goes up here to kind of this anterior part of, or the posterior part of the frontal lobe, affects the nucleus accumbens, motivation, reward, pleasure center, mood types of symptoms are controlled by this pathway. And then we have this last pathway here, the mesocortical pathway. You can see it goes all the way dorsal and superior up here, and affects more top part of the brain, thinking, higher level cognition, dementia, problem solving, attention, things that our brain, that our frontal cortex of the brain controls. So all three of these areas can affect motor, emotions, motivation, impulse regulation. So dopamine is, an important neurotransmitter for lots of different reasons, not just movement. Okay, and even serotonin and norepinephrine are affected in Parkinson's disease. So we need to think about Parkinson's disease as more than just a movement disorder. Okay, and that's where the psychology and the psychologist becomes important in your care and your treatments over the course of the disease. Because as we'll talk, you'll see that these can be hard to disentangle from the symptoms of Parkinson's disease, okay, itself. You can have depression, anxiety, apathy, psychosis, impulse control disorders, all as part of the disease itself and the neurochemical changes that occur in Parkinson's disease. Or you can have depression and anxiety and apathy as a reaction just to the situation, to the diagnosis, to the challenges that you're now faced with. Okay, so it can be both symptomatic and reactive to your disease. Okay, so we're not going to cover all of these today, but we are going to talk about the first three as they're the most common. And an important concept it took me a while to learn is that apathy can exist as a standalone condition. Okay, it can also be part of depression, but sometimes you get people who you think are depressed, and they'll say, no, I don't really feel sad. I don't feel, worthless. I don't really feel like I want to die or anything like that. I just don't care. I just don't have any interest. Nothing gives me pleasure. That's more of an apathy syndrome that exists kind of on its own. So yeah, these are the things we're going to talk about today. We have to kind of know what it is we're dealing with. So we're going to define kind of what depression, anxiety, and apathy are before we talk about how to cope with it. It's pretty common. Depression is pretty common in Parkinson's disease. The numbers kind of fluctuate depending on the studies you look at, but generally in Parkinson's disease, at least 50% of individuals will have depression. And likewise, essential tremor, dystonia, other movement disorders to a lesser degree will also have the presence of depression in those diseases. What's interesting is in Parkinson's disease that it can exist for decades. Depression can exist for decades and years before any motor symptom. Okay? So there have been a lot of studies about this, and one in particular that looked at about 20,000 people who were diagnosed with Parkinson's disease, and they kind of determined that about 10 years before they were diagnosed, they started to show the first signs of depression. Okay? Even well before movement, right? And so when we think about it, we know by the time you're showing any movement symptoms in Parkinson's disease, you've already lost, 30 to 40% of the dopamine in your substantia nigra, right? But remember, dopamine does other things too, okay? So some of the earliest signs of Parkinson's disease, what are they? REM sleep behavior disorder, constipation, loss of smell, and depression, okay? So even well before you even get that formal diagnosis due to some movement problems, okay? So yeah, it's very important. It can be a very early sign. And so when we talk about depression, we're talking about not normal sadness, but a clinical diagnosis of depression. Okay, so I want to make that distinction. We all get sad about things, right? That's normal. UK loses, right, tonight, which we really hope is not the case. I might be then in clinical depression, right, if UK loses. But we did beat U of L, so I have that too. Wait, I work for U of L.
Yeah.
Sorry. Turn that off. No, so everybody gets sad. it doesn't usually stop you from going to work, doing your job. You know, you're bummed, right? And it usually goes away and then happens again if another event occurs. That's pretty normal. What we're talking about with clinical depression is kind of a diagnosis that includes a constellation of symptoms. It has to be about 5 symptoms together that exist continuously for at least 2 weeks. One symptom of which has to be anhedonia, or just kind of loss of pleasure, loss of interest in things, and one has to be a subjective type of sadness or dysphoria. And these have to last for 2 weeks continuously. They could last for 3 months, 3 years, 30 years, and never go away, or they could wax and wane, right? We call that recurrent depression, or we call that single episode depression. If it gets really bad, you can have psychosis with it. You can have vegetative symptoms with it. And so we think about it as a continuum, clinical depression being categorized as mild, moderate, severe. And it's not always reactive. Sometimes it's just endogenous. You know, you get it from mom, you get it from dad, you're just gonna be that person that's gonna have clinical depression, right? Lower levels of serotonin, dopamine, norepinephrine. Okay, so it's not always reactive. And sometimes it does impair functioning, you know, so you are unable to work, unable to be around people, you don't want to live, you know, so you're not engaged in life. So it does, as any clinical diagnosis that we as psychologists make, any condition, whether it's OCD or anxiety, depression, it has to impair your social, occupational, or educational functioning. Right? So that's what we're talking about when we talk about clinical depression. Okay. And I kind of break it up in these different categories of physical, cognitive, and affective symptoms. Affective means how you feel, your mood, things of that nature. So we won't go through all of those because they're pretty self-explanatory, but I do want you to make note of the ones that have little asterisks by them. Why do you think that is? What's that?
Prevalence, like how often you see it.
Mm-hmm. Yeah, kind of. Any other guesses? Yeah. Yep. They're symptoms of Parkinson's, aren't they? Even if you don't have depression, they're symptoms of Parkinson's, right? And you could even throw in forgetfulness and decreased concentration, right? Because of that, quiz time, that mesocortical pathway, right, affecting the cortex, right? So you're gonna have troubles in thinking, concentration in Parkinson's disease. So you can throw those in. So yeah, that should really open your eyes and say, oh yeah, well, how do I know if it's clinical depression or if it's just because of Parkinson's disease, right? The other thing with depression in Parkinson's disease, it looks a little bit different than depression in normal Jane Doe, right? We tend to see less suicidality, we tend to see less self-blame and self-criticism, but we do see more pessimism. We do see more chronic brooding kind of rumination about things, which makes sense, right? This is progressive. This affects me every day, so I'm thinking about it, thinking about the future, right? And so the constellation of depression and Parkinson's disease does look a little bit different than that in the normal person, but of course it can vary. I tell my students, throw away the book because people don't fit in nice categories, right? They really don't. Been doing this 24 years now, and people's brains are so complex, right? And you've seen one person with Parkinson's disease, you've seen one person with Parkinson's disease. The same thing is with depression, anxiety, and psychological disorders. It's all a continuum, and there's little bits and pieces of different types of conditions. Same with dementia. So let's see. That make sense? Yep. Okay. Let's make sure I didn't miss anything here. Oh, I have to turn off the video. Okay. So from a patient perspective, what is depression? This is what some people have told me in my clinical practice, in my clinic, in my lab. Depression is a thief. It steals your life away when you should be out participating in life and you're not. I hear the second one a lot, like the heaviness weighing you down. It's like a heavy blanket weighing you down. What am I living for? These are actual quotes from people. I hear this one, bottom of a well. People have told me it's like the bottom of a well. I can't get out, it's cold, it's dark, there's no escape. This person said like a black hole inside of me that I can't fill no matter what. Oh yeah, there it is, I'm stuck in the bottom of the well, it's totally dark. Yeah, pretty powerful from patients, from actual patients, right? And then you heard of Harry Potter? J.K. Rowling? She's a little controversial these days, but this is from a long time ago. So she said depression is the most unpleasant thing I ever have experienced. It's that absence of being able to envisage that you will ever be cheerful again, the absence of hope, that very deadened feeling, which is so very different from feeling sad. Sad hurts, but it's a healthy feeling. It's a necessary thing to feel. Depression is very different. So I've kept that in there over all these years because I think as an author, it's very eloquently spoken, right, and what it looks like. But we don't want to be too sad today. So a couple cartoons, right? Well, John, in the past 2 years, you've gone from being extremely depressed to basically unhappy like the rest of us. My work's done. Thanks for laughing. I think we should cut back on my antidepressant. I've watched Old Yeller and it was hysterical. That's what I like. All right, so anxiety. Here's the prevalence slide. Okay, so general population, you can see about twice that in Parkinson's disease. Again, the range varies. It just depends on what studies you're looking at. There's a couple studies, I would say, probably about 30% is probably a good, 38% is probably a good prevalence in Parkinson's disease itself. But you have to think about kind of anxiety is a very broad term, right? There are lots of different conditions within that anxiety spectrum. You have social anxiety, you have OCD, you have specific phobia, you have PTSD, you have OCD. So there are a number of different types of anxiety. These are usually kind of a mixed prevalence number here that you're seeing. But there was a study in 2016 that kind of broke down those different types of anxiety. So generalized anxiety in Parkinson's disease, 14%. Social phobia or social anxiety, 13%. Panic disorder, 6.8%. And then coexisting, like I said, about 31%. So anxiety can take lots of different forms too. Okay. And actually anxiety, they talked about developing kind of this new diagnosis of anxiety related to wearing off periods in Parkinson's disease and medications. I hear a lot in my clinic about how people get so anxious when they start to detect their medications are wearing off. And they just get extremely worried and fearful. Makes sense if you're out in public, right, and you notice that wearing off. So anxiety can really fluctuate based on your medication effectiveness and fluctuations too. So they're toying with making that as a kind of a new anxiety diagnosis as well. But we do realize that occurs in Parkinson's disease. So that's kind of the prevalence. And here's that same categorization of the symptoms. Mood is affective, physical, cognitive, and the atrophies, as we know now, are also symptoms that you see in Parkinson's disease. So a lot of overlap again. You're not going to see these symptoms in every anxiety condition. Panic disorder, for example, like I talked about. People will go to the emergency department and think they're dying, think they're having a heart attack. Their heart is racing, they're sweating, they're choking, they can't breathe, they feel very scared. Sounds like a panic disorder to me, panic attack. Okay? So some of those symptoms are going to be very specific or more specific to panic disorder. Generalized anxiety is just that worry wart. Anybody you know just worries about everything and anything? Yeah, no matter what. They're always worrying and worrying and worrying. And they're tense and they're irritable maybe, and they're hard. They can't relax. They're restless. That's a generalized anxiety disorder. If it exists for enough time and impairs your functioning, right? OCD, we all know what that is.
Oh,
What's that?
I have that.
Yeah, it can be very impairing. I have family that has that. And it can be paralyzing because you can't do your homework that's supposed to take an hour. In an hour, you might take 4 hours to do it, because you're rewriting it, and rewriting it, and rewriting it, and rewriting it. It can be very intense, and that involves a lot of rumination and thinking and obsessing about things. So remember, you may have some of these conditions, depression and anxiety, prior to ever having a diagnosis of Parkinson's disease or essential tremor, right? And then it's the perfect storm. So then you have this maybe endogenous depression or anxiety from mom and dad, and then you get this diagnosis. So now you have the reactive response, oh my gosh, I have this new diagnosis, which itself as a disease causes depression and anxiety, right? So you've just got this, kind of perfect storm. We need to deal with that, right? And that's why we're here today. So apathy, like I said before, is a little bit different, although it can overlap with depression, right? Apathy is just, this guy says, I was trying to figure out which is worse, ignorance or apathy, but I don't really care. That's kind of what it's like. You might go to activities, but you might want to go home soon, leave early. Go late. You just sit around and watch TV all day, or just don't do much of anything. Nothing really is pleasurable. You don't get a lot of enjoyment about things. That's how I usually get at it. What do you like to do for fun? What do you do with your family that gives you pleasure? What do you like to do? Any hobbies? Stuff like that. You don't say to the patient, "Do you have apathy?" That's not going to work. But because they'll say, "I don't know." I don't care. And kind of numbness of emotions, and decreased emotional reactivity. They just don't get too excited about things, or they're just kind of flat and stoic. Okay, that might be an apathy condition. The prevalence rate there you can see, again, very broad, but there was a study, Molina 2015, that said prevalence rate of about 39% in Parkinson's disease. So pretty similar to anxiety, pretty common, right? So yeah, I'm starting to do some research on apathy at UL, so we're going to try and pull that apart a little bit in the context of deep brain stimulation and how that affects apathy. So why are these important? This, I think, is a pretty cool slide because it may be something we don't really think about too much. But basically, as a whole, it's kind of a dense slide, I know, but the take-home point is depression and anxiety, if not treated, can make Parkinson's disease worse. It can make your motor symptoms worse. It can cause a faster decline in your symptoms. It can cause a burden on your caregivers. Okay. Why might expect that is? Why would depression be a main predictor of increased disability and poor quality of life, even more than physical symptoms? And this was from, they had a study that patients who were part of centers of excellence across the country and internationally too, they interviewed about 10,000 people, gathered data from about 10,000 people, and kind of collected the different aspects of how Parkinson's affects your life, whether it's cognition or mood or movement or sleep or fatigue. And that's what this kind of bar graph is showing. The mood and depression was the biggest contributor to overall poor quality of life. Any guesses on why that might be?
Depression can keep you from doing the things you need to do.
100% right. Yeah. Depression, apathy, anxiety if you're too afraid to go out, depression if you don't, feel like it's worth anything, it's not going to help, or apathy if you don't care. You're not going to go to your PT, you're not going to go to your speech therapist, You may not even take your medications, you know, or inconsistently at least. You're not going to engage in these groups, right? Well, the worst thing you can do is not do anything, but you're exactly right, you know, but it disengages you from that process of doing what we know can help your physical and your cognitive and your emotional symptoms. How many caregivers are here? Yeah, it can have a big burden. Depression and anxiety can have a big burden on caregivers too, because you may want to encourage them. Let's go out to eat. No, you know, let's go see a friend. No, I don't do that. You know, or I'm too nervous. I'm too scared. Or they want to leave early, right? And then you can't leave maybe alone for too long or whatever, and so it affects your quality of life too, and your mental health, and so that's important to keep in mind. You know, it can affect caregivers if it's not treated. Right? So, that all make sense? Yeah. Okay. Cool. So you can see why I get so passionate about it, right? Why it's so important. Why, you know, Dr. Hedera and Dr. Holliday and Dr. Niemann, they focus, they're wonderful, amazing doctors, and they do great with cognitive and, you know, the movement piece of it. This stuff is really important too. That's why I get really passionate about it. And fortunately, they are really, really good too at understanding the psychiatric components of these diseases. So we'll see how that's an important piece of the puzzle, is working collaboratively with me and with your physicians to deal with these. So I kind of came up with this acronym. This is familiar, right? I created this a few years ago. I never have got around to copywriting it yet, but maybe eventually. So these are just my practical tips to beat depression, anxiety, and Parkinson's disease. Be engaged, exercise, activate, and then treatment and thoughts. Okay, so right about good. So be engaged. I don't care what you do, but do something. Okay, be engaged. Socially, okay? Let's get out, let's do something. Okay, we have anxiety. We're too nervous about those off periods of our medication, right? All right, well, let's think, how can we handle that? Well, one way may be to plan, you know, who you're gonna go out and do something with. Is it a friend who knows about this disease? Okay, that's safe, that's good, that's okay. Is there going to be somebody that I don't know there? All right, how am I going to handle that? Maybe I pull them aside, or have my friend pull them aside and say, by the way, I've got Parkinson's. If I shake or drop something, it's totally normal. Don't freak out. There, now you've normalized it, right? You put it out there. Okay? Have that little dialogue with someone to reduce that anxiety about what you might see. Okay? And then we talked about anxiety in the setting of wearing off periods. If you don't want to be social or go out, you know, because you're worried about your medications wearing off, let's go do something when those medications are on, right? At your best time of day. My best time of day is 8 to 10, 8 to 11, because I'm full of coffee, right? That's when I want to do the presentation. That's why I had to go get some coffee, right? Because it was 11, so it wasn't my best on period, right? But plan it, right, for when you're going to be at your best. For a lot of my patients, that is in the morning. Their medication seems to not work quite as well in the afternoon, so you know, plan that accordingly. Think about how you're going to be most energetic, most awake, less anxious. Large settings, maybe not. Keep it to small groups, right? Socially. As far as mentally, be engaged. We just like you to do anything that's making your mind think. Right? I have a whole other presentation on cognitive decline in Parkinson's disease and movement disorders, and we know from research now that doing these two things are really important to help with dementia too, and not getting dementia as early as maybe you might anyway. So mentally, we just want you to do something more than just watch TV. Even better, do something mentally with another person, playing a game, playing Trivial Pursuit, or playing Yahtzee, or anything like that. Keeping your mind active, being engaged. You're not ruminating then. You're not thinking about your disease. You're not thinking about the future. You're not worrying about stuff as much because you're distracted by whatever you're doing mentally.
And all those silly games that you think, why are we doing this? And rock steady.
There you go.
There you go.
That's it, exactly. And well, I don't want to get too ahead of the game, but I did find some research on rock steady boxing. And we're going to talk about that in just a second. And you'll see that one of the most important aspects of that is this, right? Being socially engaged, okay? And so, yes, anything you can do, conversations, reading the paper, talking about the paper, anything like that's very helpful mentally. Be engaged like you are now. I love it. I love to see you guys here. You're learning about information that can help your disease and your quality of life and your welfare, right? Support groups, education are a way to be engaged. And you're social, right? And there's this psychologist named Yalom, way back in the day, who identified like these 12 curative factors of group therapy, right? And group activities. There's this installation of hope among each other. There's this universality, like, I'm not alone. You know, and you hear someone else's story about how they got better or how they dealt with this, right? Universality, installation of hope, cohesiveness, work together. I forgot to say this at the beginning, and I apologize. I think Eric and Erica are two of the most dedicated people that I have ever met to a cause. I knew Eric back when I was on the Parkinson Support Center in Kentuckiana, on the board of directors there, a long time ago. He was one of our group leaders, and then we kind of dissolved, and he took it on himself to create what he has created and Eric has created today. Pretty amazing. Pretty amazing. And you can tell it comes from a place of passion, a place of love for you guys, and for the disease, and for improving quality of life for everybody. Erica is equally as passionate about this. So yeah, I think anytime you have that sense of cohesiveness, that sense of love, that sense of universality and commonality, it's going to help your mood. It's going to help your anxiety and your apathy. Okay. So I'm sorry, I didn't mention that at first. It was in my mind. Yes, I know you're tired of hearing it, but exercise is super important for depression and anxiety. I mean, it's kind of common sense, right? When we exercise, we release these natural endorphins in our body that make us feel good and feel better, right? And so that's kind of common sense physiologically speaking. And there's, in some cases, a social aspect that we've already talked about. But there's also actually clinical evidence that shows exercise can slow down the disease process. Some studies that talk about what types of exercise help what types of conditions. So yoga, this is coming from Subramanian Review of Neurobiology, 2017. He kind of did a scoping review of all the literature on exercise and Parkinson's disease. So this is from a 2017 journal article. But he found that yoga clinically helps depression. Significant. There's kind of this P ratio, 0.5 you have to reach for clinical significance, and it helps depression. Dance.
Yes.
Helps apathy, right? And quality of life, significantly. We have a dancer here. Nordic walking. I'm not sure what Nordic walking is, but I think it's the whole like this. Is that what? Don't get that.
Nicholas hiking.
Right. Nordic walking has to be that type for 12 weeks. Improve depression and anxiety. Okay. Tai Chi, a clinically significant improvement in sleep. Okay. Yeah. So there's some evidence to this that says exercise is important. Vigorous exercise is kind of an important component of that. Kind of, they say about 30%. It's kind of a rule of thumb from your baseline. 30% more exercise or more intense exercise than usual is considered vigorous. And then there was another study from Melly in 2021. He did a meta-analysis of 9 studies on the benefits of exercise in Parkinson's disease. And he did find that, and this exercise included aerobic exercise, dance, Nordic walking, and an equine program. Interesting, right? So exercise worked best for improvement of apathy in Parkinson's disease. Okay? And this is an element that he found also in his study, but it only was effective at a significant level when you had adapted programs with special coaches. Okay? So that was the key component there, that you had to adapt some of these exercise components for Parkinson's patients for them to be significantly beneficial, and you needed to have special coaches. Okay? Again, kind of via that social interconnectedness factor. Drum roll, please. Here it is, Rock City Boxing benefit, right? Anybody in Rock City Boxing here? I know you are, right? The poster child for it, right? So here, these are all qualitative studies, right? So qualitative is different than quantitative. Qualitative is, we just talk to you, we just gather your opinions and objective beliefs and thoughts on the matter. There are no stats being run. You can run some CHI tests.
And it's all self-report too.
So yeah, kind of self-report. But so these are pretty recent studies. I didn't have this in my last presentation, but you can see that it improved social connection. It's kind of a common theme, right? Improved in the first study sense of purpose and hope. Gave them some determination, a sense of confidence. And then in the last study, I thought was a really robust one of 1,300 people, right? And they kind of gave, clear support for improving their social life as well as depression and anxiety at pretty high rates, pretty high proportions in a pretty large sample, right? So that's pretty cool. The A in the BEAT acronym is activate. So behavior, a little bit redundant there with behavior activation. It's actually kind of an intervention we use for apathy in particular. We want to activate some activity or some goal or some purpose. And I usually tell my patients, do one daily activity at least, okay? And make it part of a routine. Okay, every morning at 10 o'clock, I want you to, do some stretching. Okay, that's behavioral activation. Okay? Or even behavioral distraction. If you're ruminating, worrying, thinking about things that are causing you to get depressed, we want to interrupt that cycle, right? And we want to distract it with anything, a UK basketball game, snapping a rubber band on your wrist, or whatever it might be, some type of distraction that interrupts that cognitive rumination that we'll talk about a little bit further slides. So yeah, just do something, behavioral activation. Get involved in proactive causes, boards, anything of worthy cause that might help you feel better about giving to others. Coping strategies and then goals are the other parts of activate. Coping strategies is just kind of what it sounds like. It's going to vary from person to person. Everybody's going to be a little bit different in what works for them. With our friend Bob, he uses art, right? Y'all know Bob, right? Yep, arts. Some people it's crafts, woodworking, music, talking, whatever. If it makes you feel good, right? That's great. It's interrupting that cycle, that mood. Please do it. Please do it. Mine is music. Mine is tennis. I just feel awesome when I play tennis. It's just like this happy place. You need to find that. Again, it might be hard to get off the couch and do that, and that's where, we'll talk about maybe medications sometimes are necessary to get you out of the dugout, right? But do what makes you feel good, makes you feel happy. Stress management is a coping strategy. We know stress has this physiological impact on our body through, this fight-flight response is evolutionarily based, right? In our need to either fight off our attacker or run away. It's the sympathetic nervous system, right? And so stress through the release of cortisol is going to negatively affect our body, and it's going to make tremor worse. even good stress, if UK is losing, you know, you're going to be stressed. So you're going to shake more, okay? And if you are at a constant level of stress, anxiety, provocation, you're going to get fatigued. Your body can't sustain that level of arousal for too long without breaking down and suffering physically from fatigue and cognitive and mood changes. So we want to activate the opposing sympathetic nervous system, called the parasympathetic nervous system, you know, where we're allowing our body to, you know, come to a lower state of arousal. You know, when we're in that sympathetic response or that fight-flight response, you know, our blood vessels are dilated, our heart is beating, you know, our lung capacity increases, we stop urinary urinary excretion, you know, we're just ready to go, right? And so we need to bring that down, and we need to train our body and learn the mechanisms for how to kind of do that. Because sometimes people who have anxiety, they don't know that they're in that state of arousal all the time. And they need to kind of recognize what those signs and symptoms are of panic or anxiety, and then when they see that, you know, try and bring that back down. So it does sound kind of simple, but it can be challenging to implement deep breathing, progressive muscle relaxation, things that help bring you to a more normal state of mind. I call it kind of the rule of three, right, for deep breathing. Breathe in for 3 seconds, hold it for 3 seconds, let it out for 3 seconds. Okay, so it's kind of like and if you do that for 3 minutes, you're going to get calmer, right? And it's going to help increase your lung capacity, slow down your heart rate, okay, and it's going to take you to a different state of mind, or a different state of physiological processing. And then with the mind aspect of it, we can do mindfulness exercises, which we'll talk about in a minute, that can help us kind of be aware of, number one, when this, you know, anxiety response is happening, and then how to kind of focus on other things to kind of get your mind in a better place. Likewise, progressive muscle relaxation can be very effective if you do it right. Progressive meaning you kind of start with the toes in your shoes, and you kind of work your way up from the calf muscles, your thigh muscles, and your abdomen, and your chest, biceps, arms, neck, and then you know, kind of hold each muscle group for 3 seconds, and then let it out for 3 seconds, and then you do that with each muscle group all the way up, or all the way down. And if you're doing that in a nice, quiet, calm, dark place, with maybe someone who's guiding you through that, then it can be a very relaxing experience. And I've done that with patients in my office before, when I used to do more therapy, and they just kind of start melting in the couch, right? Have you ever had a massage? Anyone ever had a massage, like a real one? And how do you feel after that? Yeah, you feel drunk and just kind of like, whoa, that's awesome. And that's what kind of happens after deep breathing and progressive muscle relaxation. When you do that together and do them well, it's just kind of that, whoa, this is nice. So yeah, those are some things to think about. Massage are great ways to also cope. Another aspect of activation is goal setting. I love goals, right? Professionally, I always set goals for myself every year. Personally, not as much. But goal setting can help with apathy, depression, anxiety, particularly apathy, right? But you have to be mindful of what these goals look like, and kind of how you set them up and how you think about them. We want to, you know, make goals objective, measurable, right? We want to, you know, kind of state it. I'm going to walk a mile every day, okay? We want to be able to measure that, yes or no? So we want them realistic. Don't make them too easy. I'm going to walk 10 feet. That's too easy. I'm going to walk 20 miles. That's too hard. Right? So we want something that's doable. You kind of think about your kids, right? You didn't want to make your kids, you have to get all straight A's, right? Okay, if you get like a 3.0, that's a goal for you, whatever. You want to make it achievable, so you get the sense of accomplishment. And you want to personally choose them. It has to be meaningful. Lots of research in psychology about it. If you choose the goal and you commit it socially and publicly to someone else, you're probably going to follow it. Okay, you're probably going to do it, or to your therapist. And then again, do something every day. Make that goal, schedule it, part of your routine. If it's part of your routine, like going to the gym, you know it's going to be what you have to do that day. You know you're going to come to this support group every Saturday, whatever. Just make it part of your routine. And yeah, reward yourself with something afterwards. Okay? So, yeah, goals are very important. Any questions about that? Make sense? I get excited about goals too. But medications, mindfulness, and then therapies. Those are what make up the T in BEAT. All right, so treatment and thoughts. So these are more of our traditional types of interventions that we think about for anxiety, depression, and apathy. Okay? So I do need, I'm not a physician, keep that in mind, so I'm not the one to be an expert on medications, but we deal with it a lot in our clinic just because it does affect cognition when you're on certain types of medications and can make dementia worse and can make risk of falls worse and things of that nature. But I will spend some time talking about medications, maybe pretty quickly here. So with depression, what we typically start with as the golden rule is SSRI, a selective serotonin reuptake inhibitor. So you're just dealing with one of those neurotransmitters now, right? Serotonin. And so if those don't work, we can move into a serotonin and neuroepinephrine reuptake inhibitor. So now we're dealing with two neurotransmitters. And then if we want to, we can do tricyclic antidepressants, but we don't like to do that because they're kind of old school. They come up with lots of side effects because then you're dealing with three of the neurotransmitters, so there's more likely to be side effects with those. But like an SSRI, for example, Paxil, you've probably heard of that, Prozac, Celexa, Lexapro, those are things that might ring a bell to some people. But you have to be careful and selective on which ones you choose because some of the side effects of these particular antidepressants can have side effects like orthostatic hypotension or insomnia or sexual dysfunction that are already a part of Parkinson's disease, right? So they could make it worse. Most common is sexual side effects from SSRIs. Then SNRI, the most common one there is Effexor. Effexor, venlafaxine. It helps with anxiety, but it can cause dizziness and constipation. So you have to be careful because those things are also common in Parkinson's disease. As far as tricyclics, one of those includes like amitriptyline or Elavil, and you don't really want to be on that if you can help it. Terrible, terrible for your memory. We know if you're on it for too long, it can increase your risk of dementia and Alzheimer's disease. Okay, so stay away from Elavil if you can. And then as far as anxiety, there are some medications like buspirone that are pretty commonly prescribed. Wellbutrin can help with anxiety. I'm sorry, not Wellbutrin, buspirone, benzodiazepine. If they're short-acting, like Valium, Xanax, we can give those to people who have anxiety, maybe situationally speaking, but we really don't want to give those over a long period of time. Why? Same reason, it can affect cognition, increase your risk of fall. If you're over 65, it can increase your chance of having cognitive decline, accelerate that. So don't be on Valium, Xanax, for a long period of time unless you and your doctor have good indication for that.
Well, then if they do, it's maybe time to.
And then as far as apathy goes, a little more challenging to treat with medications, but we actually think dopamine agonists, which people use for Parkinson's disease, Requip, Mirapex, those actually seem to be most effective in treating apathy. But Wellbutrin is commonly given to you. It's the medication that you might get if you're trying to quit smoking. Because why? It has a stimulating effect. It's kind of an activating drug. That's why they give it to people who are trying to quit smoking. So it also kind of energizes people who are apathetic. And then Ritalin, Adderall, you've heard of that for ADHD. That can be given for people who have apathy.
That is
well.
so dangerous.
But don't give antidepressants. That's why it's important to see a psychologist and know, are we dealing with apathy Or are we just dealing with anhedonia because of depression? Because if you give an antidepressant to someone who's apathetic, it can actually make it worse. Okay? So those are some medications that we commonly use, and sometimes are necessary. My analogy and my threshold for my patients is, have you tried therapy? Have you tried the coping skills? Have you tried exercise? Have you tried all those activation techniques? And if so, do you still feel terrible? Are you still, not better? Okay, yes, Doc, I'm still feeling terrible. Then it might be time, okay, to talk with your doctor about trying one of these medications. Sometimes people just throw that right at you and say, here's a drug, take it. I mean, that's great, but it may not be, it's not gonna be a panacea probably, from a psychologist. Because sometimes you're in that dugout of depression like we talked about, and it's just so lonely, so dark, so just, you're so helpless to get out of it. And it can really be a terrible thing. And to use a baseball analogy, sometimes you need these medications to get yourself out of the dugout and onto the playing field so that you can learn the strategies, you can learn the coping skills, learn the plays, the techniques that you need to play the game of life, right? And so those medications sometimes can boost us past that really paralyzing type of impairment in anxiety, depression, and apathy. So. Mindfulness is another technique that I do really like. I know I've talked about this before, but this is kind of those mental gymnastics that help us be very aware of our situation right now, in the moment, in the present, the here and now of what we're experiencing. Okay? It's different than like the old meditation or concentrated meditation where you're just kind of repeating a single word in your mind or focused on a particular object or corner of the room or something. This is more you're just aware of yourself. What are you aware of right now? Are you tired? Are you bored? Are you excited, interested? Is your body aching? Do you feel hungry? Where are you at right now? To pay attention to that. And it takes us from more of this reactive, impulsive kind of response to just being in the moment and knowing where we're at and what's happening with us, so that we can kind of be less impulsive. And it can be very effective. And this is all I had on the last slide when I was here. They were saying, yeah, we think it's probably effective in treating depression, anxiety, general mood, and adjustment to illness. But since that last talk that I gave a few years ago, here are some studies that showed more robust evidence that mindfulness itself can be very effective in helping with anxiety and apathy and non-motor symptoms of Parkinson's disease. Even some specific studies in 2021 that talked about improving and reducing some depression and anxiety in Parkinson's disease, as well as a 2021 study that improved apathy for those without cognitive impairment, which makes sense. You have to have some degree of cognitive intactedness to be able to be aware of what's going on, and those who have caregiver support is what Melody found, that it did improve apathy in those situations. And then meta-analysis means they looked at lots of different studies, and they kind of combined the data into one of 12 different studies, and they said that significantly anxiety and depression got better from mindfulness, okay, alone. And so you have to kind of train yourself on it. I work with my mom on this because she's somebody who's super smart, but she's just anxious and always in her head, constantly worrying about stuff, And so got her this book, and we did these exercises together of mindfulness, and she uses it a lot now to help herself fall asleep, and to help herself get out of her head when she's really dwelling on things. And so we won't have time today to do the raisins, but we did last time. If anybody was here. It was just an exercise. You can try this at home if you want to, but it's kind of an exercise to help you develop this self-awareness of the moment, where you just take a raisin, you put it in your hand, and you just start to feel it. You just start to ask yourself, what does it feel like? Is it squishy? What does it smell like? What is it if I squish it between my fingers or next to my ear? What does it sound like? And when I put it up to my nose, you know, what's the smell, and just being very aware of that. There's talk about mindful walking. When you're walking, be very mindful of your heels touching the ground and moving forward with the ball of your foot and your toes to the ground. Mindful walking. Just being mindful of kind of your body in space. So we don't have time to do that today, but if you want, I can give you the name of the book that I use with patients and my mom. And it's a really easy book to follow and read, and it talks about mindfulness in social situations and in for sleep, and a variety of specifics that are very helpful. So this is cognitive behavioral therapy. This would be done with a psychologist in their office, a psychologist like me that you would go to see if, for example, you know, you've identified someone who's clinically depressed, right? We've tried some exercise, social engagement. Now we need the help of a professional because our coping skills aren't working. Let's try cognitive behavioral therapy. So let's think about that. Cognitive behavioral therapy, right? What's cognitive? Thinking, behavior, doing something, right? Therapy, right? So we're looking at both of those components here, cognitive behavioral therapy. In depression and anxiety, our cognitions or our thoughts tend to be what? Distorted, irrational maybe, magnified, personalized, minimized, exaggerated, right? There are different terms, different psychologists in the past have used. I don't always like kind of their terms, but they call it irrational thinking, distorted thoughts, where we might, for example, if I'm giving a speech today, oh my gosh, I'm going to mess it up. Oh my gosh, last time it was terrible. Video camera's going to be on me. I'm not going to be able to talk. People are going to be looking at me. What? Right? And so those are my interpretations. I'm personalizing it. I'm probably magnifying it. You're probably thinking about, you know, the game tonight, right? Not about what I look like or what I sound like. But when you have these personalized thoughts, these personalizations or minimizations of the positives and magnifications of the negatives, it can lead to, I'm worthless, I can never give good speeches, terrible anxiety beforehand. So what do? Sorry, Eric, I can't come. I'm just gonna not go, right? I'm sick, I'm not gonna go. You know, and so then you feel bad and you feel, oh gosh, you know, so then you're tired, why did I do that? And then it just cycles, right? This example was you're criticized at work and the thoughts, I'm not good enough, gosh, I'm worthless, and that's the emotion you have, I'm terrible, I'm not good at my job, and so then you close your door and you go around and talk to people, right? And that's gonna make you feel blah, and so that just perpetuates itself, right? So cognitive behavioral therapy is, again, one of my own terms after 20 some years, is doing mental gymnastics, is what I like to call it. It makes sense, right? You're trying to do these mental rearranging of your thoughts to look at the situation differently so that you don't necessarily have that emotional response and negative cycle. You interrupt it, okay? So this is a situation with a dog in a park. You see a dog with anxiety and you think, oh, the dog's gonna attack me. So you feel afraid and then your heart starts racing and so you run away. But without anxiety, you see the dog in the park and your thoughts are, oh, that's a cute dog. Okay, so this is where you're interrupting it at. You're interrupting it at the thought point, right? You're interpreting the situation differently, right? And so then your emotions are positive, your physical reactions are more productive, and you don't run away, and you have a good response, okay? So you're interrupting it at that thought level, okay, that cognitive level. As far as the B in behavior, cognitive behavioral therapy, here we're talking about progressive muscle relaxation, deep breathing, behavioral activation, behavioral distraction. So in CBT, it's going to be a very manualized 4 to 6 sessions of solution-focused treatment. You're not going to go in and talk about your mom and your dad. You're not going to have analysis of your dreams. It's going to be a very concrete procedure that they go through to teach you CBT to help with depression and anxiety. All right, so you're going to learn first the behavioral components of how to relax, how to breathe, how to be aware of your body, how to distract yourself, and those things we've already talked about. And then you're going to learn about, the cognitive errors that you tend to make as an individual. What are you prone to do at this cycle that creates a negative emotional reaction? And then your therapist will help you, develop homework assignments. You'll go home and you'll log your thoughts that are negative in reaction to a provoking event. And then you'll come back, talk to your therapist, and then you'll say, okay, what's another way you can look at this situation? All right. And then you'll kind of go through with, that for a few weeks, and you're done. And then this is kind of a relatively new type of psychotherapy called acceptance and commitment therapy, or ACT. It's a mixture of CBT and mindfulness. I really like it. I really, really like it. I don't practice it. I have never practiced. I'm not trained in it or anything. I don't do therapy, so I'm not very patient. And I do all neuropsych testing, but I really like the concept of it in application to Parkinson's disease. And there are studies, as you'll see here in a minute, about how ACT is very effective in Parkinson's disease. And it focuses on your just the reality. What are you dealing with? Okay, can you change it? No, you can't. So what are we going to do about it? You can't change it. So what are we going to do? And you define what you're going to do based on what your values are. What's important to you? Well, you love your family, so you're going to sit on the couch and you're just going to ignore your family, but you love them. That's inconsistent with your values. So what are you going to do about that? So you can't walk as easily, or you have incontinence, so let's plan for that, right? We're going to go meet at a place that has handicap access. We're going to take the pens, and we're going to take change of clothes. We're going to make that happen because that's important for you. We're not going to sit on the couch, right? So ACT focuses on this whole diagram here. I won't get into somewhat. I don't know it super well, but again, we're doing some mental flexibility exercises and trying to be in the moment, realizing what we're experiencing. So ACT is different from CBT because we're not calling it irrational, distorted, illogical thinking. That's who you are. So you're depressed and you think this way. That's okay. That's all right. And what are we going to do about that? You're a participant in your thoughts. They're not wrong. They're not irrational. You're not a logical or bad person for thinking this. It's just that's how you are. That's who you are. What you're experiencing. So. But let's do something about that now. Let's focus this in a direction that's consistent with, what your values are and what you want to have out of life. Okay? And a good analogy that, that they use in ACT is kind of like a bus, like you're driving the bus of life. And so the passengers on the bus are your thoughts and your feelings and your emotions. Okay, and you're driving the bus down the road of life. Passengers aren't always going to be happy, right? They're going to be mad. They're going to be upset. They don't agree with you. Well, so what? You're the driver, right? You're going to stop when you want to stop because you need to stop and deal with this, right? So you're aware of your thoughts and you're aware of your feelings, but you're different. You're not defined by your thoughts and your feelings. You're different from them. And you're going to, listen to what the passengers have to say in your life, but, you're not going to be defined by that. You're going to drive the bus the way you need to drive the bus. It's consistent with your values. Okay? So that's just kind of, I thought, a helpful analogy to understand ACT. And that would be something that you go to a psychologist or clinical psychologist for. Okay? And they take you through that process. And I know I'm running late. Sorry about that. But as a scientist practitioner, we value research. We look at the literature to help guide what we do with people. And here are research studies that show ACT is helpful in helping patients with Parkinson's disease who have depression and anxiety and impacted quality of life from those non-motor symptoms. Apathy, the behavioral activation components of ACT can help re-engage patients in purpose. So I think it's a very good intervention, I really do. So just some considerations. Think about this early on in the course of your disease, in your diagnosis. Think about how you can get ahead of these anxiety, depression symptoms, and so forth. Work with your neurologist, psychiatrist, psychologist, speech therapist, and talk about these symptoms. It's okay, it's a part of the disease, don't that stigma, You know, don't let that stigma, you know, prevent you from talking about these feelings, right? It's just it's another symptom of your disease. So be sure you discuss that with your providers. And I'm glad caregivers are here, so you can understand what these symptoms might be, and can recognize them and support your spouse or your loved one in, you know, getting help. Okay. So just the closing thoughts. And that's who we are. We have 2 other neuropsychologists in the lab, as well as a couple psychometrists. That's where we are at Fraser Rehab. And if any of you haven't been to the Bill Collins Parkinson Support Center on the 1st floor, I encourage you to go. There are good resources there. It's staffed with some students. Eric have been instrumental in opening back up at Fraser, which is pretty cool. So yeah, that's how I get a hold of it. So thank you very much. Appreciate it.
Thank you.